A very good morning, and let me thank the organizers for giving me this opportunity. So, I'm sure that most of you are eagerly waiting to return to your places, and to some extent, you all will be bored. I can imagine. Okay, sitting for some time. So, let me just tell you that if you want to ask something, please try to be interactive if you want to ask something. And it's not going to be something like a very new topic and some rare thing. No, it's the everyday business. Knee examination we all do every day, even though now we have the our probes and ultrasound everything, but we do depend a lot on clinical examination and it's necessary. So first of all, you have many conditions now. For all these conditions you have to do this clinical examination, and always remember that all the things we see may not be arthritis, deformities, the ligament, but many of the things we are seeing it usually postural issues, or whatever you are seeing a major thing is there, an osteoarthritis patient is there or ligament injury is there, there may be an associated or underlying postural issue will be there. So you must be able to identify these things, and a lot of that comes from experience, but as nurse are already told, but a lot you have to read many things to get that. So if you have not that much idea now, but try to get it from now onwards, it's very important. And look for all these things definitely. And do these photos seem similar? Have you seen them somewhere? So have you seen these photos somewhere? So anybody who thinks that they are similar, I just even if you think that I have seen it somewhere vaguely, please raise your hands. If you think that you have seen it somewhere, these things, somewhere, very old fashioned photos. Yeah, where? No, probably a good. Maybe that there is some photo like this. I have not seen that. That's why. This is, if you have not seen this, this is the old book Kendall and Kendall. Okay. If you have not seen this, if you do not have that vague memory of seeing this, you must see this. Okay, why I am saying is that you can read all the biomechanics books and everything, but basically you must have some basic idea. These things are very important because what are you seeing? Is there anything important in these things? Any abnormality do you see there? What do you see there? Genu valgum and verm. It's very yeah, genu valgum, but it's very gross. See, so this is la. This is almost normal. Now you are here. You can see the internal rotation of patella, and here there is basically there's some pronation. Okay, so here then again there is similarly, but here the internal rotation is more. You can see here. Okay, so the thing is that one thing you must always remember is that when you cannot take knee, hip and ankle isolated. They are interconnected. All the joints are interconnected. These weight bearing things are totally interconnected. And one idea you must be having in this, you must be you must have good expertise in assessing the supination, pronation, and you must know how is a close kinetic supination, how is a close kinetic pronation, how the subtalar joint moves. So that is very important, pretty important when you are assessing these things also. So this shows actually the femoral internal rotation. Okay, so that's very important. So when you just have a look, you can see many things like this. Okay, here you can see that it's internally rotated, but this way it's almost okay. But here you can see here it is internally rotated, and here that is actually supinated. You can see the tibialis anterior standing out there. Okay, so that gives you some idea that here these things you cannot do much by interacting some, doing something here. It's unlikely to affect this knee because here it's okay, not much issue, but the problem is here may not be that much of a problem, but you when you assess postural issues, these are very important. Here this is fully externally rotated, here it is hip externally rotated, here external, here pronator, everything is externally rotated. Okay, now it is the ideal thing. Now there is going to be some flexion over here. So similarly, it must come to your mind is that the quadriceps is overloaded. So to stand like this, some amount of this posture, the quadriceps is always overloaded. You can expect some amount of anterior problem, anterior knee, something patellar issues in this patient. Here there is hyperextension. And what is the attitude of this ankle? No, ankle. What's about ankle? Yeah, that's plantar flexion. And also, you may be knowing that I'm just telling you that always remember that any joint movement, this is dorsiflexion, this also is dorsiflexion. Always have an idea. This is hip flexion, but this tilt is also effectively that is hip flexion. Those is closed kinetic and open kinetic. You must be very experts in that. This is okay. There is a structural varum, structural valgum. Here is a postural. So what have postural things? Okay, postural bow legs and postural this thing. This is an interesting. This is a postural valgum, and this is the same person. So how this correction has happened? How this correction has happened? This is the same person. This is the same like this one. This is a postural valgus. How this correction has happened? Knee hyperextension. Knee hyperextension is the way to. So all these things, whenever a patient comes, look for all these things. Have a good idea about all these things. What all things you see, and you must have a picture in your mind. This patient is likely to have. And then you have. I'm not elaborating on the gait. Make the patient walk and walk him for some time. Have a good walkway and see the patient walking and think about what is the problem. Maybe an antalgic gait, maybe a pseudo-waddling gait, or maybe some amount of simple things. Now you can see inspection, you can see an effusion, you can see a Baker's cyst, and the quadriceps lag. You may be knowing the quadriceps lag. Parallel tracking we will mention a bit late. Of course, the gait, ROM. Okay, you need to measure the ROM properly with a goniometer. But after the exams and all, you will be all probably doing the visual assessment. So you must be an expert in doing a visual assessment also. Then the palpation, the temperature, the ballotment, the patellar tap test, and the tenderness in various areas. Now, the medial knee, these will be the structures, the major bony structures you are having in the medial knee. And these are the soft tissue structures. You are having the medial collateral ligament and the pes anserine bursa, all these things. So actually you come from side of your side of the patellar ligament and come down. Okay, you can just keep your finger on your own knee and the patellar ligament on the side, and you can feel it coming down, and you will get the tibial plateau over there. Okay, then flex it and go up from the tibial plateau. You will get the medial femoral condyle. Okay, and from there you can flex, and this way you can actually palpate the medial joint line from backwards, from plateau, just step and backwards you can palpate. And when you are going for the meniscus, actually you can internally or externally rotate and palpate from the medial joint line anterior to posterior coming down. You can look for the bursa anserina over this area. From here to here you will get the medial collateral ligament, and below you will get the anserine bursa, and you can actually palpate the tendons. Which are the tendons? You have the sartorius and other things, 3 tendons you can actually palpate over this area. So that will be over the medial knee. Then coming to the lateral knee, you have these bony structures and soft tissue, the ligament, lateral ligament, the iliotibial band, and these things. Again, you go on this lateral side of the ligament patella, and you will get the. So you can again go down, and here the thing you will get the lateral tibial plateau over there. Okay, you can feel it over the lateral side, and then you can actually move up. Again, similarly, you can get the condyle when you move up. Okay, then you can actually flex it and find it more prominent, and then you can go down and look for the fibular head. From the fibular head, try to get this thing, your CPN over there. Okay, then from the fibular head, other thing you can get is from the fibular head to this area actually goes along with our biceps femoris long head. A biceps femoris will be the fibular or the lateral collateral ligament. It will be from here to here going the lateral collateral ligament. Then you will have the biceps tendon also you can palpate. Then the another thing, major thing you will be having here over this area will be the iliotibial band that goes up to. From there you can get it as, you can just feel it over here. Okay, now you can feel it over here. It's very important to have a proper idea regarding the palpation. Okay, so the palpation, I always think that You have a, when you have a linear probe, actually it will tell you whatever things are inside. But our hands are also fairly good enough. That can also tell you whatever things inside. And extra thing is that the hand can usually tell you about the functional problem inside. That a linear probe cannot tell you. Okay. So I was actually telling that now we are becoming less and less efficient people, especially personally, I think less and less efficient for taking clinical examination, because now we are using a lot of ultrasound, because whenever we see the patient, we tend to keep the probe and see the things. Okay. So this is whatever we mentioned about the anterior knee. Then coming to the posterior knee, there is no video about the posterior knee. These are the things. Then there are ligaments. Okay. Then all these ligaments, ACL, PCL, you know all the ligaments, there is no need to repeat all these things. So then the basic, I divide these tests into, there are tests that those are routinely done, and you are all well aware of these tests. You are all doing, and you are many times read and these things. But there are some other tests which are not that routinely done. And then there is an issue is that these tests we are doing, they may be sensitive specific, or they may be just routinely done because we have read about this and we are doing it for years and years. Okay. So that's the point I am trying to concentrate on. So the anterior Droy's test, I am not going into the, can you please, that's actually telling me that I should, oh yeah, thank you. Yeah. So this anterior Droid test, we all know how do you do the anterior Droid test. Just translate it up to the anteriorly and posteriorly and look for the end feel and the just translation. Latchman, the essential difference is that your flexion is less, around 15 to 20 you go and you just do, and always try to remember to keep your thumb on the tibial tuberosity. Okay. And here the thing is that Latchman is good. So your order will be Latchman, then the anterior Droid test. Then the pivot shift test. Okay. The pivot shift test. So the pivot shift test for these things, that's a functional, it's good, and to see after the restoration, after surgery, whether there is restoration, this is a good test. Basically what you do, why you call it a pivot shift test? What is the pivot and what are you shifting? Why you call it a pivot shift test? Basically what you do is actually you are shifting when there is the anterior ACL is not there. When you give a valgus stress, actually it subluxates from here. And then when you give flexion, okay, valgus stress you can actually subluxate it, and when you give flexion, what happens? You have your stretch on your iliotibial band, and that actually take it back. So that is the thing that you are looking for. Then this is a test that is not usually done, but this is said to be a very specific test. This is the liver sign test. Actually, when you push it down, it acts as a lever. This is the fulcrum. So when I am pushing it down, this will go up. When this connection is proper, this acts as a fulcrum and it will go up. The heel will go up. But when this connection is not here, the ACL is gone, this heel will not go up. It's a very specific test. Not much studies have been done, but whatever studies have been done in good samples, it shows a specificity somewhere near to 100%. Okay, it's a very simple test also. Just keep it like that, keep your palm, hand as a fulcrum, just press here and you can see that it comes up. It's a very simple test. So then for the posterior sac sign, the posterior droid test, one point about the posterior sac sign, whenever you are doing the anterior droid test, first confirm that there is not a posterior sac sign. Otherwise, relatively that will feel as a positive anterior droid test. Then this is a test that is not that much mentioned. This is a quadriceps active test. Here what you do is you try to just contract the quadriceps slightly by moving this foot forward, and when there is a PCL deficient knee, the tibia will slowly anteriorly translate. Otherwise it will be held there, but with this small contraction it will anteriorly translate. Okay. Minimal contraction of the quadriceps. Minimal contraction, make him minimally contract the quadriceps and just look for whether it is anteriorly translating. Normally it will not translate anteriorly. So that is the quadriceps active test for the PCL. Then the valgus and varus stress test, you know that you can do it with the 30 degree of flexion and then 0 degree and 30 degree flexion, give the varus and valgus stress. Then coming to the patellofemoral test. Patellofemoral test is important, like your kind of many of the postural pain and other things which is coming from up also, they usually come as the patellofemoral pain. There you must be aware of the Q angle. I think all of you know about the Q angle. So always you must know how to measure these things. So that's a practical point. You should not be like for the exam you are doing it for the first time and you are keeping the axis somewhere here, somewhere there. That should not be. You must know the points, how to connect it and how to measure it using a goniometer. Then you must know about the patellar tracking. So mal tracking usually that go in the lateral way. Okay. You can see that. This is not an error, this is a stolen video, okay, but you can see it properly, okay. So that is J sign, and then different tests with the patella, okay. You can actually move the patella, to see the mobility. You what you do is you actually make into 4 quadrants and you check the displacement whether it is less than 4 quadrant displacement, keep it in slight flexion and move the patella, okay, to check for the mobility of the patella. Then you are actually here also it has to be bit more slight flexion. Here you want to see whether the lateral patellar retinaculum is tight. You are just shifting it. And the shift, they say the angle and all, but don't go for the angle, but you can just check whether the patellar retinaculum is tight. Then you have the apprehension with both thumbs pushed to this side. For when there is a displacement, the patient will be apprehensive and he will try to extend it to correct the subluxation. So with both the thumbs, push it from the medial side. Then another test which is not usually that mentioned, that actually a step, patient is keeping it on standing on one step and the other leg, so he will be doing like this, okay, standing on one step and basically like this. I will show the video also like this, okay. So there you look for 4 strategies: arm strategy, trunk movement, pelvis, knee position and the stance. Like whether he is doing the arm strategy for the balance or the trunk movement, then the pelvis movement, then the knee position, like knee crosses this an imaginary line from the second toe, whether the knee crosses this second toe or the knee crosses an imaginary line from the border of the foot. So here is 1 point, 1 point, 2 point, 3 point, 4 and the foot 2 point, and when there is any balance issue, whether there is any balance issue. So this is the way they do it. Okay. 5 times they have to do. So you can check the arm strategy, the pelvis, the trunk, and whether it is going beyond this area, this toe or this toe, and whether he is losing balance. This is purely fully normal. Then for the menisci, I am not going to the detail, the McMurray test, apply grinding. Basically, this is not a preferred test. It has got a very poor, and the procedure also is a kind of not a nice procedure, and it's very poor sensitivity and specificity. But probably this test is Thessali not done too much. It's a good test. It gives an idea regarding, actually you make the patient to twist around with a 20-degree knee flexion 3 times and whether to see whether there is any pain. 20-degree flexion and just turn around. You can check for any pain. That's the Thessali test. Then the bounce home test. This is also a very good specificity. Yeah, what are you doing? You are keeping it, you are taking the foot in your hand and just extend, and that normally that kind of bounce back. See, it just boom, like that. That's a normal. If it's a mushy end feeling, that's likely to be a indicative of some meniscal problem. Then there is this is a short list for OA. Actually, it's from the Arthritis Research Canada. You can actually have a checklist. This has got a very good specificity in inter-writer reliability and all. You can check for the effusion gait, flexion contracture. Effusion, so you know the bulge sign. So a gross effusion, you can see the patellar tap, but if it's not that much, bulge sign, just squeeze here, out. After that, you clear this side, use this side of it, then plus, and you can see, okay, how it comes. I just want to show you once more. So always make a habit to do this. Minimal effusions you can easily detect by this. And actually this was a patient for whom a tapping was done last week. See, this bulge coming. So I can clearly say we have done the ultrasound also. There was a very little, maybe 2 to 3 ml of fluid there. Then this is the patellar tap, you know that. Then look for the flexion contracture. Then muscle strength, tenderness, all this we have demonstrated. Bony swelling, crepitus, end of range, lies this thing, end of range, stress pain, range of movement, and the ligament test. Then the extension lag, quadriceps anterior power, and the quadriceps atrophy. All these are for osteoarthritis. This is for the extension lag when you have a passive extension full and the active extension is less. Okay. Then you have a quick approach. It's either it's an acute traumatic or then or chronic. So the problem with the knee is either acute traumatic or it's a chronic overuse. Inspection, then have a proper gait evaluation, palpate for effusion. This is like a practical approach, not an exam approach, practical approach. You then do a 90-degree flexion, patient supine, then look for the joint line, lateral condyle, ITP, pars anserina, make the patient supine, look for the patellar tendon, patellar, retropatellar tenderness, distal pulse and sensation, make the heel to buttock, extend the knee and kick your palm cap 18 inches. That shows the quadriceps mechanism is fairly okay. Then rule out any issue with quad mechanism. Then the varus and valgus test, the order is Latchman, drawer, liver sign, pivot shift. Then posterior sac, posterior drawer, active quad. Joint line tenderness, McMurray, Thesali. J sign, patellar apprehension, tenderness, medial patellar. That is the order, practical and the sensitivity order for these tests. Then overuse injuries, the major thing is that always don't forget about the proximal things, obertus, cos strengths, because all these things, the femoral internal adduction, internal rotation, and the abductor mechanism, all these things can affect the knee. So never look into the knee as an isolated entity, always look up, always look down. Okay, so these tests are very important. And hip strength and tightness, ankle and foot attitude and deformity, core strength, overall posture. Always think of these things, the gait and all these things, the hip, ankle, their attitude, their deformity, their strength, everything, and check the gait also of the patient. So that's in short about what you can make about knee. Okay, thank you.